with that interesting data, let's talk a little bit about what we all do. Adam, do you test PD-L1 in all patients who have metastatic triple negative disease?
Yes, I do, and I'll just answer the second question too. I do PD-1 L1 testing by SP142, and the assay does matter, yes.
And Ian, do you do that as well? Do you get a repeat biopsy, or do you use the archival tumor tissue?
Well, again, as we talked about with the ER positive patients, it's certainly important to get a biopsy to confirm the diagnosis. It is interesting, there's this, as you pointed out, that the metastatic patients, metastatic biopsy samples generally have lower levels of PD-L1 positivity. Whether it matters which one you measure from sounds like it's still a little bit unclear. We tend to measure off the metastatic sample, but a lot of times from a timeline standpoint, it's easier to get the archival sample and get it done. So I don't think our institution has a specific policy. We generally try to get we want to get the results quickly so that we can make a decision regarding their first line therapy.
And, there's a lot of discussion about we had seen that initial data with monotherapy checkpoint inhibitors that looked encouraging and then kind of discouraging. Then we saw Keynote 119. Adam, what's your take on that? Does that mean that pembrolizumab is not effective, or is it more the trial population and the single agent treatment?
It could be both. I think that these are more heavily pretreated patients. I think it's interesting, though, when further analysis was done on 119, it appears that the patients with a CPS score of 20 seem to actually have a benefit. And that's probably consistent with the patients who have a high tumor mutational burden. It's not a huge number of those patients, but those would be the only ones I think I would think about using Pembro in this setting, if I use it at all. I think right now I would not generally use immunotherapy after the first line, absent convincing data, with the exception of these patients that maybe have high tumor mutational burden, but that's about it.
So you think that the differences with 119 had to do more with line of therapy than using single agent? Ian, do you share that idea? Is it more is there any difference between agents that we know about? Is there something special with giving chemotherapy with immunotherapy?
Well, so I think those are three very good questions. It does appear so far that at least in the metastatic setting that being PD-L1 positive predicts benefit both of the combination with chemotherapy as well as single agent. I think as Adam pointed out, somebody who has a very high PD-L1 level may respond to checkpoint inhibitor monotherapy, but from the data from Impassion 130 and now the hint that we're hearing from the checkpoint 355 study, you're seeing a benefit when added to chemotherapy. The overall outcomes in terms of response rate are much higher. So I think for most patients with triple negative disease, you're clearly more likely to see a benefit in terms of response when it's done in combination with chemotherapy. So I think for most patients and from a practical standpoint, it makes sense to use a combination. In terms of whether there's a difference between pembrolizumab and atezolizumab, obviously we don't know for sure since we haven't seen a comparative trial, and we probably won't for who knows how long. But now that we have the data from 355, at least knowing that it met its endpoint, my guess is there probably is not a big difference in terms of outcome. They both seem like they're beneficial when added to chemotherapy. And again, as I said, I think for most people, that's the right way to use them.
So I agree. I think that there's something different about the responsiveness of our relatively immunologically cold disease that we specialize in when we give chemotherapy with checkpoint inhibitors, and that there are, as Adam pointed out, some patients who may be uniquely sensitive to checkpoint inhibitors as single agents, because many of us who did those single agent trials have a single patient who's far out on their checkpoint inhibitor, but it was only an N of 1.